Hello, and thank you for joining us today for the 2022 State of Survivorship Survey results. Before we get into the survey, I just want to point out that today is Founders Day for NCCS. It is the day that 36 years ago, a group of people got together and they wanted to address the issues of cancer survivorship because people were surviving longer with cancer, and they created the National Coalition for Cancer Survivorship. So we are grateful to them and that what they started, and our survey helps provide the data about the challenges that cancer survivors are still facing. I also want to mention that one of those founders, Dr. Patty Gans, will be recognized at our Stovall Awards reception in 3 weeks. We're excited that she was selected to be one of the 2 recipients of the Ellen Stovall Award this year. And so now I'm very excited to get into talking about our survey. This is our 4th year to conduct the State of Survivorship Survey, and we've worked with Edge Research every year. They've been a fantastic partner, and I'm really thrilled that Pam Loeb of Edge Research will be here to present the results of the survey. And so I'm just going to give you a little bit of background on the survey before I turn it over to Pam. So next slide, please. So as I mentioned, this is our 4th year to do the survey, and I just wanted to share a little bit about what we're trying to accomplish and what's new this year, and then I'll turn it over to Pam to go into the results in depth. Every year we build on our previous surveys and what we've learned about patients. And I think what's really important about the surveys, we're really trying to understand their experience with cancer from diagnosis through treatment and through post-treatment survivorship, and really understand what are their attitudes, what are their needs, what are the challenges that they face. We ask about satisfaction, and we find a lot of satisfaction with their care, but we really wanted to delve deeper this year and understand, break that satisfaction or that their experience with their care down into different points in the cancer journey, and better understand both the screening and diagnosis, the treatment, and then the post-treatment care. And through our survey, as we've continued to expand our sample size over the years, we have the ability to understand better about underserved audiences, who they are, what their challenges are, and how the system can better meet their needs. And we really try to explore, what does coordination of care mean? What are the costs of the disease? And when we think of costs broadly as not just financial costs, but also time, physical challenges, mental health challenges, work, sacrifices to work and education. We'll cover all of these. So now I'm going to turn it over to Pam Loeb of Edge Research. We have loved working with Pam and her team. They've been a fantastic partner over the 4 years of doing this survey, and she is an expert on this data, and she's going to take us through the survey results. Pam?
Yeah, thank you. Sorry, just too fast on the trigger there. So, I mean, Shelley gave a really good overview of what we tried to accomplish this year. Just a note on the methodology. This was actually the largest number of cancer patients surveyed over the 4 years of this research. So we interviewed over 2,000 cancer patients, and we had a few different phases of research. We always start with a qualitative phase where we sit down with patients and survivors and talk to them about their experience. And that just ensures that as we're asking these questions, they're really based on lived experiences. And we continue to kind of fine tune the research instrument based on those conversations. Most of the data that I'm going to share with you is from what we call the national sample, or the nationwide sample of over 1,400 cancer patients and survivors. We make sure that the survey is representative by age, gender, race, ethnicity, and region, using the most current ACS and NCI data. And as a companion to this, we also survey what we call the NCCS connected group of patients and survivors. And those are people who NCCS communicates with on a regular basis through email, etc. So you'll see that data kind of pulled out in yellow as a comparison. As we're going through, sometimes we'll point out where there are statistically significant differences by audience. So numbers in blue mean higher, red mean lower. And then there are a few cases where we're just noting changes from last year's survey. So an up arrow means the numbers are higher, a down arrow means the numbers are lower. And NCCS will share the full report of this data, but just to give you a quick preview on what we'll be covering and how we approach the study a little bit differently this year, as Shelley mentioned, we really do a deeper dive into each stage of the cancer journey, from screening and diagnosis to treatment and care to and post-treatment care, and then look at the costs of cancer, and what people have experienced both physically, emotionally, and financially, and really as information to help you as advocates and practitioners understand how you can better help patients. And then last but not least, every year we have kind of a hot topic or a special section. This year it's around integrative oncology, so I'll share a couple of slides around that. So to get us started, over the years, we have asked patients how satisfied they are with their treatment, their cancer treatment and care. And we've really focused on that specific aspect of the journey. And majorities of patients continuously express a high degree of satisfaction. Then we have these qualitative conversations, and there's really a disconnect with what people first say is satisfaction and then go on to tell us just a number of different problems that they encounter along the way. So this year we decided to drill down more granularly. Are there areas where patients are more or less satisfied, and really take a look at each aspect of the journey? So at a macro level, you can see that over 6 in 10 say that they are very satisfied at each stage. However, if you kind of look at each of these stages, the highest degree of satisfaction is during treatment and care, and the lowest are kind of at the beginning during screening and risk assessment, and at the end, post-treatment care. So 10-point difference between treatment and care. And as I mentioned, you know, when we've been in these qualitative research sessions, we have seen this disconnect between the ratings that patients give and then the journey that they describe. So this is just an example from 3 of the interviews that we had this year. In all cases, patients told us that they were very satisfied with their cancer treatment and care, but then went on to explain a number of different situations that they encountered. So looking at the quote on the left, this was a young adult, tells us, you know, she was very satisfied. She felt as if her healthcare providers were very attentive. But before she was diagnosed, it took 3 years to find out that she actually had cancer. And she goes on to talk about the fact that her doctors did not believe her when she said she was in pain, told her it was psychosomatic, stress related. 3 years later, they figure out, yes, in fact, she has cancer. And that's why she says they must be more attentive to me, because it took 3 years. And I won't go into all of these because of time, but we hear stories like this again and again. So what we decided to do is we decided to kind of look at all of these different points in the cancer journey and see if there are different segments or audiences with different experiences. We used a methodology called segmentation or cluster analysis. This is an analytical tool that allows us to sort people into mutually exclusive groups based on similar attitudes and experiences. You can see the inputs that we had for this model on the page here to the left. And then to the right are kind of the 3 different groups and the size of each group. So about 7 in 10 people who took this survey almost, really had a mostly positive experience, which is great news for the field. But then there's another quarter that had a more mixed experience. In some cases it was good, in other cases it was not. And then just about 6% who had a continuously negative experience. And while these 2 middle groups are only about a third of patients and survivors, that is a substantial number. And it's important to really understand who they are and what the field needs to do to help them. So here we give you a sense of how their experiences differ on all 6 stages of the cancer journey. What we're showing here is the mean score on a 5-point scale. So to the right, is higher, very satisfied, is a 5, that's the highest score. 1 would be very dissatisfied, that's the lowest score. And you can kind of see how those with the positive experience in green, the degree of difference between them with a mixed experience in blue and a negative experience in red. And where they are kind of furthest apart is on the beginning of the journey, screening, risk assessment, and diagnosis, and the end of the journey, post-treatment care. There are also some real differences by demographics. So some of these we've seen across studies, but this has really helped us kind of crystallize some of these differences. So those who are more likely to be in that mixed or negative group skew slightly more female. They're more likely to be African American and Hispanic. They're more likely to be younger, so under 65, particularly 18 to 39 years of age. They're also of a lower socioeconomic status, so they're less likely to have a college education. We don't show income on this slide, but also lower income as well. And then psychographics also come into play when we kind of break down by experience. So part of it is kind of time and memory. Those who are still in treatment and are not kind of in that survivor category yet are more likely to be in our negative experience group. Stage of diagnosis and current health situation also come into play, of no surprise. So let's kind of get into each of the different stages and look at the data by stage. So here we're looking specifically at screening and diagnosis. And you can see how these average scores on both screening and risk assessment, as well as cancer diagnosis, really vary by the 3 groups. A couple of things to point out with our negative experience group, and I'll show you some of the data to back this up in a moment. They're more likely to say that they've had symptoms for longer. They're more likely to have seen more doctors prior to diagnosis, and they're more likely to report being misdiagnosed initially. So looking at length of symptoms, this chart basically shows you the incremental percentage of how long it took to get diagnosed over time. So if we look at kind of the top line, the national sample as a whole, about a third of people said that they had no symptoms before they were diagnosed, basically found out they had cancer at a routine checkup or by chance. We get to 1 month, about half. And if you get to 5 years, about 97% said that they were able to have a diagnosis. But if we look at some of these groups in red, where the numbers are lower, meaning these groups were less likely to be diagnosed within 6 months, there's a couple of key subgroups that stand out. Younger cancer patients, 18 to 39 years of age, waited longer to be diagnosed. African Americans, Hispanics, I just want to point out that 2 in 10 Hispanic patients said that after 12 months, they still had not gotten a diagnosis. And I think that's a really important stat to point out. Those who are living with metastatic cancer and those in the negative experience group also had symptoms for longer before they were diagnosed. And kind of related to this is the number of doctors that people saw on average before they got that initial diagnosis. Overall, it's about 2, but again, there's some groups that stand out who saw more doctors, and that correlates with just taking longer to be diagnosed. 18 to 39-year-olds, Hispanic patients, and those in that negative experience category. And then we have slightly more than 1 in 10 who report having an initial misdiagnosis, 13% overall, but this is 2.5 times higher among 18 to 39-year-olds. Also higher among those with a negative experience. And then of interest, those who have a relationship with NCS are twice as likely to have been misdiagnosed. And it makes sense, that they went and sought out NCCS as a support system and as a source of information. So now we're going to get into some of our mindset questions, how people kind of approach their cancer journey. And we asked people, which of the following two statements describes you better? We have a little over half who say that they wanted to find out all of they could about their cancer diagnosis and treatment options from the get-go. And that group, of no surprise, is more likely to be those who've had a positive experience with their cancer care. We have more, this correlates with biomarker testing and genetic counseling. This group is also more likely to be of a higher income, be more educated, and interestingly, have a STEM background. And then we have about 1 in 10 who admit that they didn't want to think or read about cancer and hear about all of the bad things. Similar numbers say that they tried to ignore their symptoms and they delayed going to the doctor for as long as they could before getting a diagnosis. So there's definitely a group of people who admit to kind of sticking their head in the sand and not being able to handle the information. Speaking of information, when we asked people what were their top resources, um, the three that rise to the top for the sample as a whole were patient education materials that they got from either their doctor, the hospital, or their treatment center, going to websites like WebMD or a fan favorite, Google. For the NCCS connected group, they were 4 times more likely to say that they went to a patient advocacy organization as their primary source of information. So, NCCS, a primary source of information, much lower among the population as a whole. And then last but not least in this kind of first section, we did want to understand how many people had their healthcare team offer or discuss a clinical trial with them. So about 1 in 10. And then we also had about 1 in 10 who said that they participated in a clinical trial related to their cancer diagnosis. And there are some groups that kind of stick out in terms of being more likely to participate in clinical trials. You can see them at the bottom of the page. Of no surprise, those who are younger are more likely to both be offered a clinical trial and participate in one. Now we move to treatment and care. And one of the questions that we've been tracking over the last 3 years is how much people rely on their doctor to decide on treatment options and choose the best course of action for them versus really be proactive in researching and deciding on what they think are the best treatment options for them. Back in 2020, by kind of a 3-to-1 margin, our sample really relied on their doctor, what we call doctor knows best. And then in 2021, we saw a sharp decline in the number who said that they relied on their doctor and a big uptick in the number who said that they were more proactive in their decision making. So we continued to ask this in 2022. We wanted to see if maybe this was COVID effect, people being more proactive in their healthcare, but also not maybe having access to their healthcare professionals as much as they did in the past. And we start to see the numbers kind of even out a little bit more. We still skews doctor knows best. We have more who say there's some in the middle, and this year, less than last year, the number who say that they were proactively involved. And again, to the right, you can see groups that were more likely to be proactive in their decision making, younger, higher income, STEM background, college degree. So now we get into satisfaction with treatment and care. And as I said, this number has been consistently high over the years. of patients this year said that they were very satisfied with their treatment and care. And this is highly correlated with perceptions of healthcare providers. So you can see to the right that 7 in 10 said they felt as if they could always talk to their provider about their concerns, like they were listened to and respected. And this year, and kind of because of COVID and some of the feedback that we gotten in qualitative, we also added in a trust question. And we had 8 out of 10 who said that they trusted their healthcare team completely. But of no surprise, some of the more underserved groups rank lower on almost every dimension. Women, African American, Hispanic patients, um, those who are still in treatment, as well as in some cases younger patients. And I just want to point out to the right that there is like a 20-point difference on trust from the sample as a whole versus Hispanic patients. So lower trust in their healthcare provider. And speaking of healthcare providers, we drilled down and asked 2 questions. We asked who people visited or went to for care, and that's what you see on the bars at the bottom of the slide. And then for people who went to each type of provider, we asked how helpful they were in uh, in aiding them during their treatment. And you can see, and this has been very consistent over time, oncologists and surgeons were seen by the greatest percentage of people. Um, very strong scores in terms of how helpful they were. Next is primary care physicians. About half of people said they saw primary care physicians during their care and treatment. Satisfaction numbers with their PCPs is lower at just 69%. And then far fewer are likely to say that they interacted with any of the other types of providers that we see on the slide here. Lowest numbers are pain specialists at 9%, and only 50% found them to be helpful. So here again, we're looking at this dimension of treatment and care and breaking it down by our positive, mixed, and negative experience groups. And you can see the discrepancies on trust, and some of these other more soft dimensions, like feeling as if they could talk to their healthcare professional and as if they were listened to. And to the right, we see some of the quotes, some of the feedback that we got from people in the survey. So from the positive experience group, one of the reasons that their trust numbers are so high is that their healthcare providers made them feel safe. They built a relationship with them. They appeared to be interested in both them as well as their family. I can't tell you how many times people wrote in good eye contact. So for the providers who are listening, I mean, that just goes a long way. And also the fact that they were patient, open, honest, and accessible. On the negative side, people described their relationships with their providers as bullied, ignored, act as if I was lying about my symptoms, told me I was overreacting. I felt like a number instead of a patient with individual needs. So you can see how different those experiences are. We also, over time, have asked some questions around symptoms because we hear a lot in our qualitative interviews about some of the symptoms that people experience that they never anticipated. So we have a list of 23 of kind of the most common symptoms among cancer patients. And looking at all of those, about 9 out of 10 or 86% of patients say they experienced at least one symptom during treatment. The average number was almost 5. The most prevalent is fatigue, followed by depression, anxiety, and mental health issues, loss of appetite, nausea, and vomiting. And if you look to the right, and you kind of see those blue numbers, which means significantly higher, there are several groups that are more likely to experience a number of different symptoms. Women, African American and Hispanic patients, those younger patients, metastatic patients, and those without a college degree. This year, we expanded this question to not just ask about what symptoms they experienced during treatment, but also what they experienced immediately after their treatment was completed. And for those who are no longer in treatment, what symptoms they're still experiencing today. And if you look at those numbers in the top, that's just the collapsed view. So I already told you that 86% said they experienced one of the 23 symptoms during treatment. We had about a quarter who said they experienced symptoms after treatment was completed, and about 6 in 10 who say they still experience symptoms today. The most common of which are those related to depression, anxiety, and mental health, sexual issues, a lot of prostate cancer patients in the survey sample, as well as neuropathy. And even today, on average, patients experience over 2 symptoms far after maybe their cancer treatment was completed. So, in terms of healthcare professionals addressing these symptoms and informing patients about what to expect, 6 in 10 said that they felt very informed about potential side effects from treatment, although that number did drop a few points this year. To the right, you see the kind of top symptoms experienced out of the 23 that we asked about. And for each person who experienced any of these, we asked a follow-up question, which was, how helpful was your healthcare team in addressing those side effects? And you can see that on the majority of these, less than half would say that their healthcare team was very helpful, with the exception of nausea, diarrhea, um, skin rashes, fevers, chills, mouth sores, and high blood pressure. But for things like depression, anxiety, loss of appetite, fatigue, people less than half said that they really felt as if they got the support they needed on those most common symptoms. And this is kind of related to another topic that's come up again and again, not just in the qualitative, but in some of the open-ended questions that we ask, and that's around coordination of care. And last year we asked a question, how well do you think your healthcare providers coordinated your care? Like this year, although the number went down a little bit, large numbers say very well. Similar numbers say they felt as if their healthcare providers shared results with one another and reviewed their records, but 54% said that they had to share information from one healthcare provider to another all or some of the time. So definitely some confusion about what we mean by coordination of care. Of no surprise, this is something where our 3 different experience groups have very different experiences, not to say the same word twice. And to the right, you see some of the qualitative feedback that we got in the survey around this. So somebody with a positive experience around coordination of care, talking about how their primary care physician was really instrumental in working with their surgeon, helping them find the best oncologists and radiologists, and just being there for them throughout. But on the negative experience side, feeling as if they just kept filling out form after form after form, constantly repeating the information in the room with the nurse. Then when the doctor comes in, repeating it again and not feeling as if anything that they had provided in advance or over time had been looked at. And then on a somewhat unrelated note, one of the topics or one of the themes that came up in our qualitative interviews that we just wanted to drill down into a little bit more in the survey was around the stigma related to a cancer diagnosis. So we asked a couple of questions. One question was, how comfortable were you telling people that you had cancer diagnosis? And the good news is that only 17% said that 17% said they felt uncomfortable. This number is slightly higher among women and Hispanic patients. And if you look to the right, or actually, let me wait on that one. And then we also asked a question based on some of the feedback that we got in the qualitative, which is, did you feel pressure from others to remain strong during your cancer treatment? About a quarter said yes. Again, higher among Hispanic patients, also higher among younger patients and metastatic patients, as well as those in the NCCS connected group. In talking to people in our qualitative interviews, you can see a quote to the right, which is quite indicative of what we heard. And this person said, I had to pretend like everything was fine, like I was just going to get a tooth pulled out because this was not something my family could handle. And this person feeling as if they needed to be able to take a step away from their family and do some type of group therapy in order to figure out how they could express themselves and not keep everything bottled up. Now we're getting to the last phase of the cancer journey and some of the feedback that we got around post-treatment care. So we had about 6 in 10 patients who said that they were very satisfied with their post-treatment care. I do want to note that this is 10 points lower than satisfaction with in-treatment care. And kind of related to this is the fact that less than half say their provider did a very good job helping them make the transition to post-treatment care with another provider. We had about 28% who just couldn't even evaluate on this dimension, which I think just points to the fact that patients have some confusion and in some cases low expectations at this stage. So when we ask people what topics healthcare providers discuss with them regularly during post-treatment care, majority said follow-up tests that I need to get to monitor my cancer, but then the numbers really drop. Very few are talking about quality of life, exercise, nutrition, physical function, mental and emotional function. Some of the symptoms that we know are ongoing, like fatigue. And some are just not interested. They just want to get in, get out, and not think about it. Except for our negative experience group. So in this is the group that is 2 times more likely to say that their doctor doesn't bring up any of these quality of life issues with them. And in every case, they're more likely to want their team to be proactive, whether it's discussing post-treatment issues like mental health, exercise, nutrition, and or the fatigue and pain that large numbers of those who are in this group say they still experience. The past 2 years, we've asked a number of different questions around COVID and the impact on the patient journey. This year, we just asked one question, which was how much impact did COVID have on surveillance appointments? So we had about 6 in 10 who said that they did not experience any delays or postponements in appointments during the height of COVID. We had 15% who said that their appointments were delayed, but they still got checked eventually during this time. And then we had about 14% who said that they either didn't get checked during COVID, 8% who said they didn't get checked during COVID, but they resumed their checks today, and 6% who said that they have not been checked since the start of the pandemic and have yet to resume monitoring or surveillance checks. And a lot of those are, again, some of the underserved audiences that pop up again and again in this study. Which leads us to some of the costs of cancer. So we've gone through the journey. What are some of the costs that people bear along the way? Over the last few years, we have been asking about people's concerns on a number of different dimensions: physical, emotional, as well as financial. And we have seen, of like 30 different items that we test over time, the same issues consistently rise to the top. You can see them here on the screen. What is so interesting about the findings this year is that more are concerned about almost all of these issues in 2022. So a lot of these numbers have ticked up this year, particularly those related to finances and insurance. So we see more people worried about the cost of care, prescriptions, non-medical expenses, and caregiving in particular. So really seeing the impact of this economic downturn on the cancer journey. And particularly, again, among some of the most impacted audiences: women, 18 to 39-year-olds, African Americans, Hispanics, metastatic cancer patients, those without a college education, and our two kind of more disenfranchised groups, the mixed and the negative experience groups. When we asked about some of the specific financial impacts that people have had because of their cancer, they range from things like having to spend savings or retirement to cover living expenses, to needing to borrow money from friends, applying for government financial assistance, delaying major purchases, and the list goes on. We have about half, or 47%, who say that they have been impacted in one of the ways that you see here on the left on the screen. And then if you look at the top of the slide, you can see that all of this is more prevalent among, again, those same audiences: younger cancer patients, people of color, metastatic patients, those who do not have a college degree, and those in our two um, mixed and negative experience groups. And majorities also say that they've had to make employment and education sacrifices. The most common thing is just having to miss work. But we also have 2 in 10 who said that they had to work fewer hours, 15% who say they lost salary and wages, some people who've taken an early retirement. Again, the same groups are more likely to have experienced these employment and educational sacrifices. So the last section, again, is that kind of special topic that we asked about this year. The survey was getting quite long, so we decided we would ask this among the most vested, which was the NCCS connected group. And these are some questions around integrative oncology. So first, we wanted to understand, since people were diagnosed, which of the following, if any, have they used to help treat cancer and or its side effects? And this was a multi-select question. The most common was some type of movement or exercise, followed by dietary supplements, massage, mindfulness, prayer, and relaxation techniques. We had about a quarter who also tried yoga, and 2 in 10 acupuncture. Of these different interventions, the ones that get the highest scores on efficacy are movement, massage, prayer, as well as mindfulness, relaxation techniques, and yoga. And interestingly, among this NCCS connected group, 8 out of 10 did some type of form of integrative oncology as defined by these variables to the left. The average number was 4. And interestingly, higher among Black, Hispanic patients, as well as those with a STEM background. As people think about the reasons for using these integrative approaches, it's really around just maintaining a general sense of well-being, coping with emotional or the mental health impacts of cancer, as well as managing symptoms. Those are kind of the main reasons that people turn to integrative oncology. And there were few who said that there were really any barriers. The biggest barrier was just not being aware. Followed by just 10% who said it wasn't covered by their health insurance. So those are the findings in a nutshell. There's more data to be found in the full report. I'll let Shelley give a shout out to their generous supporters.
Thank you, Pam. Thank you very much for presenting that. I've been answering some of the questions as we've been going through, and the NCCS team has been answering questions, but please feel free to submit your questions and we'll direct those to Pam. But before we get to questions, I do want to thank our sponsors. Bristol Myers Squibb was the initial sponsor for this and has sponsored the survey for 4 years, and we're very grateful. And our other sponsors are Pfizer, Genmab, Kite Pharma and Takeda Oncology. And we're really grateful to all of those sponsors for making this happen. And I also want to thank the NCCS team. Everybody worked on this and put this together, and the wonderful team from Edge Research, which we love working with you all. And I also want to give a shout out to Jackie Huck, our amazing designer, who helps make all of the graphs look even prettier and easier to understand. So it was a real team effort to pull all of this together. And thank you all very much. So one question is, and I mentioned, I've been answering some of the questions as they went through, but someone asked, who was able to respond to the survey? I know that for the NCCS Connected, those are people who learned about the survey from us. So that means we sent it to our email list, we posted it on Facebook and Twitter. So I would say there's 670 respondents in the NCCS Connected group. And I would say many of them are advocates who are actively involved with us. Not all of them. Some may just have learned about it from us. They may just follow us on Facebook or get our emails. But that's how the NCCS Connected group was recruited for the survey. Pam, can you talk a little bit about how you recruited the other respondents?
Yeah, so we used a national online sample provider. We've used the same provider over the years that we've done this study. This is an organization that we have a relationship with, verified participants. Millions of people are on the survey panel. They are compensated for their time, so they do get a small incentive to participate. And what we do to make sure it's representative is we set what we call quotas. So we look at ACS and NCI data, and we make sure that we have a representative sample by key variables like age, education, income, gender, race, ethnicity, and region.
Great, thank you. So there was a question about, there were definitely some questions about the other types of providers who weren't in the top 10. I know that one slide that had the list of providers seen and how helpful they were was only the top 10. And so I think, we can, if people have questions about the other types of providers, you can get in touch with us and we can share that, but we really only focused on the top 10 in that slide. And so one question, and this is maybe something we can think about for next year, but since we saw that the mental health concerns are not being addressed as fully, it might be worth asking more pointed questions about who on the team provides the mental health support. And I think that's something, I don't know, Pam, what you think, but we could consider for next year, because that might be helpful to sort of pinpoint if they're getting it, and if so, who on the team is the one that's sharing that information.
Definitely. Yeah, we have asked some questions around other support systems like family, friends, healthcare providers generally. But we have not really drilled into who specifically is providing mental health support. So it's a great idea for a topic for next year.
There's some questions about receiving the recording and slides and full report. All of that will be posted on our website. And so you can go to canceradvocacy.org. And we'll put the link in the chat to the survey, to the specific link to the page on our website that has that. And there's also a question about whether the report will be available to those who participated. It's really available to anyone. And I don't believe, Pam, that we collected email address for people who participated to send it back out to them, but maybe you can confirm that.
Oh, in the survey?
Mm-hmm.
Yeah, I don't think we did. We just had kind of an anonymous link that people could click on, right, just to protect their privacy.
Mm-hmm. There's a question about, do we have information about what treatments patients received? And we did ask that question. Can you talk a little bit more about what we learned there? I don't remember. I know that we didn't cover it in detail in this report.
Yeah, I need to find it. So go on to the next question and I'll find that while you're looking at it.
And there was another question about what integrative services were covered versus not covered by insurance. We didn't ask that specifically about each of the type of integrative services. We just asked generally about barriers. Is that correct, Pam? And not specifically to each one. Yeah.
Yeah, no, we just had a few questions about that at the
Great. Um,
uh,
Go ahead.
oh, so in terms of what types of treatments, we asked about the range: surgery, chemo, radiation, targeted drug therapy, immunotherapy, bone marrow transplant, palliative supportive care, biomarker testing, genetic counseling, and another treatment. Um, the most common two were chemotherapy and targeted drug therapy. I'm sorry. I'm looking at the wrong thing. So the most common are surgery, radiation, and chemotherapy. We had about a quarter who said that they had genetic testing and about a quarter who said they had biomarker testing. Those were two new things that we added this year.
Okay. And with the biomarker testing, there was a question about did we get any information about how that affected decision making? I don't think we did, but I just wanted to confirm that.
Well, I think we did have one data point that I shared earlier, which is that people who, and let me just grab this and make sure I'm reading the correct thing. People who had biomarker testing, I believe, were more likely to say that they were proactive in understanding their diagnosis and treatment options. So there was a correlation between those who had biomarker testing and those who agreed with the statement. I wanted to find out everything I could about my cancer diagnosis and my treatment options. So there's definitely a correlation between being more proactive and having that
Mhm.
type of care.
Great. And did the data give any information on whether COVID impact the stage of cancer diagnosis? I know that that's something that's been of a lot of concern. I don't think that we got at that, but I just wanted to ask you to address that.
Um, Explain and
I
exactly.
think that there's a big concern that people are being diagnosed later, or will be diagnosed with later stages of cancer because of missing screenings during COVID or not being able to get in to see a doctor when they have symptoms. So that there'll be more patients presenting with metastatic cancer during and after COVID. I don't think we got at that, but I just wanted to
We
ask
could
you.
look at, we did not drill down on that specifically, but we have the data to look at that. So we could look at people who had to delay their care
Mhm,
by how long they had symptoms before they were diagnosed. I just can't, I don't have the
mhm.
data to do that on the fly, but we could look at
You can?
that.
Great. Um, And then someone asked how many respondents. So there were about 1,400 in the national sample and 670 in the NCCS sample. So
Yeah.
a little over 2,000 combined. And let me see. Did we, I don't believe we broke it down this way, but we probably could. The information on financial stressors and challenges broken down by the type of insurance.
Yeah, we can do that, and I actually looked at that before we got on the phone because we had talked about that. And interestingly, those who have private insurance are overall more likely to say that they had financial concerns than those with public insurance, but that really has to do with age.
Mhm.
So younger respondents more likely to have private insurance, 65 plus, Medicare, um, which is why I think we see those differences.
Yeah. Um, this question says, do you ask patients if they had genetic counseling prior to genetic testing? We asked if they had biomarker testing and if they had genetic counseling. We didn't ask about the sequencing of any testing. And I think that it's probably important to state that the biomarker testing is not the same as genetic testing. We ask about genetic counseling. And then biomarker testing is really only patients who are aware they had it. I think that probably understates the people who actually had it because it may have been done, by the pathology team. They don't even know what was done. So the question we specifically asked was if they had genetic counseling. Let me
Yeah,
see.
and we did not give like a definition for either. We just said biomarker testing and genetic counseling.
And someone also asked about is fertility being discussed early on so patients can do fertility preservation. We did not ask about fertility preservation as a service or if that was a provider that they saw. We asked if that was a concern. So I think that's something we could certainly consider is or ask if they're being asked about it early on so that they could. I know that it's more common in this commenter said it was not discussed 23 years ago. I think we're doing better now than we were 23 years ago, but it's probably not often enough. So that's definitely something we could consider for future surveys.
Yeah, we asked a couple of questions about it, as you said. It did come up in a couple of our in-depth interviews, where I'm just thinking about a couple, maybe one or two young women that we spoke with who had talked about that with their provider and taken steps to, um, preserve their eggs.
There's also a question of do we have it broken down by different cancer types? I know we know the different cancer types who responded, but I'm not sure that we have statistical significance to do all of the breakdowns by cancer type. There's certain things we can do. So can you talk about that a little bit?
Yeah, so basically the most common group, the most common cancer types and the ones with a large enough sample size to look at differences are breast cancer, prostate, skin, cervical, colorectal. But otherwise, I mean, I think we looked at 30 different types of cancer, and then we had an other catch-all category. We don't have enough completes to really break down the data. Um, that's something we can think about in the future, or if there are certain cancer types that we want to oversample. But all of the other types, we are like kind of the proportion is in the single digits.
And thank you. There's a question about what percentage of the respondents were Hispanic and Latino. Do you have that available? I know it's on one of the and it when you download the report, there's some appendices that have breakdowns by a number of different demographic breakdowns. So you can see more detail about that. We didn't go through those slides, but they'll be in the report that you can download.
Yeah, about 10%.
Great, thanks. Did we look at satisfaction of care by where they got their care, whether it was at a community cancer center or local or regional cancer? I know we looked at that last year. Did we look at that this year?
We do have the information. I'm looking to see if it's in the data that I have in front of me. We did not, there were not a lot of differences, honestly, um, which is why we didn't report it.
Okay.
So, one of the things that we have found in the past is that there is some confusion as well. Like we ask about academic medical centers, and people both over and under report on that. So, one year, I think we had people write in exactly where they had their cancer treatment, and one of our interns coded every single response to make sure that it was accurate.
Mhm. And it was in a lot of cases not accurate because I
Correct.
think people don't think about I mean, we may know what an academic medical center is, but you don't necessarily think about that. You just know where you're going to get your care.
Yeah.
Um, so this question is, did people define their symptoms that they were reporting that were ignored? It was really the way we asked it is more like, what are the symptoms you had? And then how helpful was your healthcare team in addressing? So it wasn't necessarily ignored, but it was, the disconnect being when they said that they had these symptoms and they didn't feel like their healthcare team was as helpful.
Yeah, that was the quantitative question. I mean, in the qualitative, the idea of symptoms being ignored came up again and
Right.
again, particularly
Mhm.
with our kind of mixed and negative experience groups. And that has been a theme that we've seen throughout all 4 years of this study.
Yeah, great. One question is just how long did recruitment take or how long was the survey available and what was the name of the survey sample company that we used?
Um, the survey was in the field for almost a month, July 12th through August 8th. And Dynata is the name of the sampling firm. Used to be Survey Sampling. Now they're called Dynata.
Okay, great. And then this question is, when you use the term surveillance, do you mean for tumor recurrence or late effects? I believe it is really about tumor recurrence, but I can go back and look at how we phrase that question.
Yeah, I'll grab it.
Okay.
Keep going and I'll come back to it.
Okay.
We said when it comes to monitoring or surveillance checks for your cancer, which of the
Okay.
following best describes your current situation?
Okay. So I think the implication there is that it's for cancer recurrence, but generally that the survivorship visits are structured around a check for recurrence. And then that's when ideally those discussions about symptoms and quality of life would happen. But as we saw that's not always the case. Great. There's a question, will future surveys ask about those who sought clinical trials? I think that we didn't specifically ask if the survivor was the one to really look for the clinical trials. We asked if it was offered to them.
Correct.
Yeah. Great. There was a question, did you ask anything about survivorship care plans? We did not include that this year, I don't believe, but I know we have in the past, and it was about 20% that received one. And I think we can definitely consider including that again next year. Somebody asked if you want to take the survey next year, just follow us on Facebook or actually go to our website, sign up for our email list, and then you'll get it. We don't necessarily have a list to sign up for the survey, but if you sign up on our website to receive our emails, then you will be informed next year when we have the survey, and we will definitely do it again next year. Here's a question. Did you ask any questions about the caregiver support they may have had? We did, and that is we didn't go through all of the support questions during the webinar just to make sure we had time to go through it, but there are some slides on that in the report that you can download. And I don't know if Pam, you can say anything about that.
I know, I'm trying to find it. So yeah, we asked a couple of questions about how critical different players were in helping individuals through their cancer treatment. So we had about 67% who said that their healthcare team was critical, 54% who said that their friends and family were critical, and 42% who said that their faith was critical. Faith definitely comes up in our qualitative conversations.
Yes. Mm-hmm. The question is, do you plan to do a survey with caregivers? Yes, that's something we're talking about for next year. We would love to do that. We think that would be really important. And then you might want to ask about telehealth, particularly for mental health issues. We have asked a pretty extensive list of questions about telehealth last year, and we continued that this year. Those, again, will be in the report. We just didn't spend time on them in this webinar. And we asked about satisfaction with telehealth, and also, do you prefer in-person or telehealth for a range of different types of visits? So that is in the report if you want to see that. There's also a question, what is contributing to the confusion around coordination of care? And I really think it's just the fact that nobody knows what that means. Somebody also mentioned that the disconnect between the how people rate the quality of their care and the qualitative discussions means could mean that they are not comfortable expressing dissatisfaction. But as we've talked about, really the biggest reason that people rate their quality of care high is they're so grateful to be alive.
Mm-hmm.
And so I think, when you ask about a question of, was your care coordinated? It's probably not something that the average patient thinks about. We think about it a lot because we work on healthcare policy and we're trying to improve the healthcare system, but it's not something people think about. And so again, they're grateful to be alive. They give high marks. I just don't think it's very well defined. And I think even looking at, there's not necessarily a consensus definition of what care coordination means. So even people in health policy don't necessarily know that. So the average patients who participate in the survey are not necessarily going to know what that means. So when asked, they just say, yes, it was good, because they're grateful to their team. I don't know if you would add anything to that, Pam.
Yeah, I mean, the only thing I would add is we did drill down a little bit more this year with some questions around, did you feel like your test results were shared? Did you feel as if your electronic records were shared? People said yes, but then we asked, did you have to repeat yourself, multiple times? And everybody said, yes, I did. So, or not everybody, but 54%. So,
Right. Yeah. Well, we are at 1 o'clock, so I think we should conclude. But I just want to say thank you again to everybody for joining us today. To thank you to all of the respondents of the survey who shared about their experience. It's not a
yeah,
short survey because we ask a lot of questions and people really take the time to complete it. And it means a lot to us because we use this data to really inform the work that we do. We share it with policymakers. I've already presented this a few times to smaller groups and giving them a little bit of a preview before this webinar today. And it's something that there's a lot of interest in. So we're really grateful to everybody for responding. And thank you to our partners at Edge for making this such an amazing product every year.
thanks, Shelley.
Thanks, everybody. Thank you for joining us today. Have a great day.